or whatever. So there's this lack of interest. In my area, there is no neurointervention. So neurointervention. So I'm from just outside of Cape Town in an area called Somerset West, which is 50 kilometers out of Cape Town near Stellenbosch, which hopefully some of you have been to. It's beautiful winelands and very nice retirement area. And we have our hospital here with all the emergency stuff. But it's a small hospital. I'm in private practice, so the patients have medical insurance. So I'm not in a government hospital or an academic institute. There are 3 cardiologists. I'm the only one doing stroke. There's 6 physicians and 1 stroke physician. Always be called. They always call him 24/7 if he's not available. They will call me or one of the other physicians. We only have 1 cath lab, we've got 1 CT scan and 1 MRI. I've done about 120 stroke cases, started with Mercy, Solitaire, and Trevo. We get referrals, because we're the only cath lab for about 250 kilometers. So how did I first get involved? I was doing carotid stents, and I was thinking, well, what am I going to do if I get a peripheral embolus? So I thought I must have something on the shelf in case I get an embolus during stenting, and I got this Mercy device, not to use an acute stroke, but to bail me out. And that was available in South Africa. But then the stroke unit head, and this is critical to any cardiologist here, and I've had a couple of you guys speak to me, starting a program is you've got to have your stroke physician refer you the patients. They've got to believe in this type of therapy, otherwise you get in the water. You're not going to get a unit operating. So I had the stroke physician approach me and said, these big strokes don't do well with thrombolysis. Many can't get thrombolysis. Can you help me? And I mentioned this earlier, I wanted just to say with the NINS study, functional outcome at 1 year, if you look at the strokes scale size, TPA versus placebo, good outcome, you can see here that TPA makes no difference in your large stroke and your very large stroke, absolutely terrible outcomes. And the NINS study, no mortality difference between TPA and placebo. So we keep going on, give lytic, but this is the lytic data. They've got class 1A registration. Not particularly great for your large and extra large strokes. So how did I get involved? How did I start? I did flow model training in our cath lab with Concentric, who's now Stryker. I did some internet research looking at the stroke literature to see which units do the most stroke interventions. And at that stage, it seemed to me I'd toss up between either Buffalo and Nick Hopkins unit or Marilyn Round's unit at Kansas City. And both of them were quite happy for me to come and observe. And that's where I went, hoping to see lots of acute strokes. But needless to say, it was a quiet week and I only saw 1 acute case. But what it did allow me to do was go over the previous cases and watch a neurointerventionist in the cath lab. And as I said, it's quite different to cardiologists. When I see a guy putting catheters up and there's no pressure monitoring on the end of that catheter, it's quite different to the cardiology, where everything's on pressure monitoring. So I thought this was an invaluable experience, and I'd recommend it to anybody starting. Go to a neuro lab, spend a week observing, and I think it's a lot of value in that. So my first case was pretty straightforward case in the sense that it was a lady who had asystole during hip replacement, and they did CPR. And when they tried to wake her up, they found, she can't move, she had CT angio, she had an ICAT occlusion. So really they came to me and said, there's nothing we can do, can't give a lytic. She had a stroke on the table, or can you help? So I said, well, I can't really do her much harm. So took her to the cath lab, and obviously it was quite disconcerting passing one's wire for the first time through an occluded, yes, the carotid occluded. So we just had this triple flow. As you can see, she's intubated because she never really woke up post anesthetic. But to take a wire across the head here, where you've got no angiographic guidelines, was pretty disconcerting. So what I did, I took a picture of the other side, I had that up as a roadmap, so I just knew, well, mirror image, that's where I had to go. Obviously, for my carotids, I knew, where the middle cerebral artery is, because we do angiographic studies of the brain after we put a carotid stent in, but still, I found that was quite a valuable thing. And that procedure clinically, angiographically, went very well. The lady had a massive stroke and had died. Died a few days later. So what does our stroke unit consist of? It's not really a unit, and some people have fancy buildings and so on, and labels all over. We don't really have that. It just really is a team of personnel and a pathway. So there's a stroke physician in charge. I'm the interventionist. We have drawn up protocols for the emergency unit, and we do try to educate them, but the staff do turn over, and you get locums in, and so on. So sometimes they don't exactly follow the protocol. We speak to radiology, but again, you get some radiologists. We're about 10 radiologists at the hospital where we work. Some are keen on neurointervention, some are, neuroimaging, some aren't, and it depends who's on call. Our patients go to this cath lab, to the cardiac care unit. All our stroke patients go to the cardiac care unit to give an IV thrombolysis post-cath lab. Our CCU nurses are trained in looking after these patients and doing neuro-ops, and we obviously have all the other supportive therapies. So this is our protocol that we've drawn up. If it's an infarct less than 4.5 hours and it's a smaller stroke, we'll give the IV TPA. And if failed, if it's running, we may wait an hour or just as the infusion ends before deciding to go to cath lab. But a large stroke, we know, as I've shown from literature and our experience, TPA is not going to work. We may start it, but we're not going to wait. We will take those patients directly to the cath lab. And then over 4.5 hours, we'll go to the cath lab. And delayed stroke, if it's very big, we may go straight to the cath lab or get more complex imaging. So as I say, how to start, you must have a unit. You're going to be part of this team, and your stroke physicians have to want to refer the cases to you. You need to be experienced in carotid interventions. I think that's really the minimum, although as I found, and Horst mentioned earlier, just anecdotal, that the acute stroke cases, the carotid anatomy, for whatever reason, doesn't seem to be as severe or so many type 3 arches as we see in the carotid interventions. I think it's important not to have everybody trying to be involved, and because we don't do that many cases, I'm the only one who does it. If I'm here, well, that's tough for the patients. One needs to actually obviously read the stroke literature. You have to be knowledgeable in the cerebral blood supply, and obviously be available. It's always disruptive. These cases, they're going to come in the middle of your day or the middle of your night. You need to educate everybody about what's happening, and we give a lot of talks and have to repeat the talks because people are always changing, involving the local physicians' ERs. It is a lot of work. And I think it's important to review your results and outcomes. Are you actually making a difference? And I've published some of the stuff. The first 5 cases I published in our local cardiovascular journal. And then the first 25 cases I published in CCI in 2010. So funding in South Africa wasn't really an issue because the patients are insured. Some of the funders said, hey, they don't want to fund us, and that's again involved a lot of meetings and educating. But we do occasionally get devices not funded, or I don't get paid, but well, I just accept that that's just how it is. And I think learning from experience is the most important thing. I'm a single operator, and this is where Omar, I think it's important to rely on pen pals, as I've called them. Now I have pen pals, and Horst is one of them, Chris White at the Oshner Clinic, and Nick Hopkins, who's left. If I have a difficult case or any concerns like you had, I make a copy, I email them that day, and I say, look, this is what I had, how would you have handled this case? And I tend to, within a day, I'll get answers back and say, look, and so I learned from that experience, and I think it's really important. I think that's been invaluable for me. So in summary, you need to be a member, you need to get trained, educate everybody, be available, look at your results, learn from others with more experience. And I think this slide sums it up, but I can tell you by far it's the most rewarding work that I do. Thank you very much.